Good afternoon, everyone. We're going to get started. My name is Bridget Burns. I'm the Senior PAR Specialist at the American Thoracic Society, the ATS. Welcome to the 7th installment in the 2020 Lung Disease Week at the ATS series and to LAM Week at the ATS, which runs this week from July 12th until the 18th. The webinar today is entitled Looking Toward the Future in LAM and is being presented as part of the LAM Week educational programming. This program is a joint partnership between the American Thoracic Society and the LAM Foundation. First, we need to inform you that the subject matter discussed here today is designed for educational purposes only. Therefore, you should not rely on this information as a substitute for personal medical attention, a substitute for direct medical care, or as a substitute from diagnosis from a physician. If you are in need of immediate medical help today, please consult your family's healthcare provider right away. Do not wait for a response from our members, staff, or partners. If properly logged into the webinar, you should be seeing my desktop and hearing my voice via your computer speakers. Some of you may be dialing in with their telephone and should have been provided a toll-free number, access code, and an audio PIN. If you are dialing in with your phone, please turn down or turn off completely your computer speakers to avoid feedback. After the presentation, you may ask questions by clicking the question sign icon and type a question into the chat box that pops up. The question comes to me and I'll relay the question to the presenter. Let's get started. First, I would like to acknowledge our partner, Mary Harbaugh of the LAM Foundation and a member of the ATS Public Advisory Roundtable, PAR. Mary will also introduce our speaker today. Mary, welcome.
Thank you, Bridget. First, a few words about the LAM Foundation. It was founded in Cincinnati, Ohio in 1995 by Sue Burns, the mother of a LAM patient, who partnered with Dr. Frank McCormick to develop an organization that provides support and education for women with LAM and their families. In addition, the LAM Foundation has worked with patients, clinicians, and scientists to develop an understanding of LAM, set up over 60 LAM clinics around the world, which have also helped to advance the understanding of LAM, and this has resulted in an FDA-approved treatment. Dr. Nishant Gupta will be presenting today. In 2017, Dr. Gupta was named the medical director of the LAM Clinic Network. Dr. Gupta is a pulmonologist who is also board certified in internal medicine. He earned his medical degree from the University College of Medical Sciences in Delhi, India, completed his residency at the University of Tennessee College of Medicine, and a fellowship from the University of Cincinnati Medical Center in pulmonary, critical care, and sleep medicine. Today, Dr. Gupta will be presenting to us on looking toward the future in LAM. Dr. Gupta?
Thank you very much, Mary, and also Bridget. Before I begin, I also want to thank the ATS for the invite and really giving us a forum to talk about LAM. And I've structured the talk essentially in two halves because I figured there might be some new patients here. So I'll, in the first half, provide a brief overview of LAM. And in the next half, we'll talk about some of the new stuff that has come or is going to come out with regards to LAM research. And we'll leave a few minutes at the end for questions. But before we talk about LAM, let's spend just a few minutes on the topic that it seems like we cannot go by a few minutes without mentioning. So I'll start by just mentioning that in case some of the patients here are not aware of it, that we have provided a 3-tiered risk assessment for LAM patients with regard to their risk of COVID-19. And this is a table that summarizes it, and essentially we divide the patients into a mild risk category if you have a lung function greater than 70% and you're not on sirolimus, a moderate risk category if your lung function is greater than 70% but you're on sirolimus, or your lung function is between 50 to 70% whether you're on sirolimus or not, and severe risk category if your lung function is less than 50% or you're requiring supplemental oxygen, or you're either undergoing transplant evaluation or you are a post-lung transplant patient. And this is general guide, this risk for individual patients depends on a number of other factors, including comorbidities, etc. But we thought this would at least be a helpful guide for patients to make decisions about their risk. And the link at the bottom of the slide takes you to the LAM Foundation's page, where we have provided answers to a lot more questions that routinely come up with regards to COVID-19 and LAM. So please take a look if you haven't so. And this is a slide which is a recommendation for all LAM patients, regardless of which risk category you fall into. Most of these are things that you probably have heard, but these are important, and I would like to at least reiterate them. And so the first is that you should pay attention to and adhere to the directions from your local and state authorities. This is a pandemic that has affected the entire world, but for individual folks, the risk is really dependent upon the local disease prevalence. So be mindful of what the local spread in and around you is. Wash your hands with soap and water, or use alcohol-based hand sanitizer frequently. And keep in mind the CDC recommended guidelines of at least 60% alcohol in the hand sanitizer. Clean and disinfect frequently touched objects and surfaces using regular household cleaning sprays or wipes. Avoid touching your nose, mouth, or eyes with unwashed hands. Sneeze or cough into a tissue or inside your elbow and don't use your hands. If you are sick, please stay at home. Continue to follow the social distancing guidelines, maintaining a 6 feet distance between you and other people. As much as possible, avoid gatherings of more than 10 people. Avoid eating or drinking at bars or restaurants. Use drive-through, pickup, or delivery options at least as much as possible. Wear a mask when going out in public, especially in situations where social distancing is difficult to maintain. Prime examples for this would be going to the grocery store or going to a pharmacy. We often also hear from LAM patients that wearing a mask makes it difficult as far as breathing is concerned. And we understand that, we acknowledge that. A couple of solutions to that is sometimes there may be a problem with just getting used to wearing a mask. So for some patients, it may be helpful to try practicing wearing a mask at home and see if that starts helping. And for others, keep in mind if you are going outside in a well-ventilated area with not many people around, it is okay for you to not have a mask. But if you're going to be inside in areas such as grocery stores and pharmacies, please try to wear a mask as much as possible. And restrict all travel, all non-essential travel. The other question that comes up commonly is with regards to Sirolimus and COVID-19, and this question really goes in both directions. So the first is whether being on an mTOR inhibitor such as Sirolimus or Everolimus increases the risk of complications from COVID-19. And the short answer is that we don't know, and the likelihood is that that's probably not the case. But given the potential for lung function decline off of Sirolimus, we strongly recommend that LAM patients do not stop taking Sirolimus as a precautionary measure. The other way this question is asked is, can Sirolimus have a preventative or a treatment effect in COVID-19? And again, the answer to this question is not clear. I will say that this is the subject of an active investigation. So hopefully we will know more about it in a few months, but as of now, the decisions regarding Sirolimus should solely be based on LAM. So to further simplify this, if you're on Sirolimus for LAM, please continue taking it and do not hold it because of COVID. And if you're not on Sirolimus currently, your decision to start Sirolimus should be based solely for LAM indications and not as a preventative or treatment agent for COVID-19. What is the real life experience of LAM patients with COVID-19? We are only aware of a handful of LAM patients who have had COVID-19. Just to clarify, that does not mean that LAM patients are uniquely protective against COVID-19. It simply, I think, reflects the fact that LAM is a rare disease. Overall, all of the patients that we have known have recovered well and not required prolonged hospital stays. Whether COVID-19 will have long-term effects on lung function in patients with LAM is an unanswered question. The Tuberous Sclerosis Alliance is collecting data for patients with TSC and LAM who have had COVID-19. If you're interested in collaborating or giving your data to this endeavor, please contact either the LAM Foundation or Joanne at the TS Alliance, and her email is here in the slide deck. And my last slide on COVID-19, I just wanted to at least mention these few points, is that just keep in mind that every decision in COVID times is based on probabilities, your individual tolerance for risk, and quality of life. We are all going to have to learn to live with this virus for a while. But the thing to keep in mind is that if you pay vigorous attention to the principles of hand hygiene, social distancing, and mask use, you are for the most part in control of your risk. And if you follow these rules, you will not get infected. And lastly, keep in mind that the best minds in the world are all united against finding ways to treat and prevent COVID-19. The scientific world has come together against this crisis in a way that we've never seen before. And we will make it through this. And there will be systemic changes that come out because of COVID-19. Which I think will make us stronger and better in a number of different ways. And I'll share one concrete positive that will come out of it towards the end of my presentation. So let's shift focus to LAM. So just some key points for every LAM patient is LAM is a simple neoplasm that is easy to decipher. The average survival of women with LAM is greater than 20 years post-diagnosis. The diagnosis of LAM can be confirmed in over 2/3 of patients without needing a lung biopsy. Sirolimus is an effective suppressive therapy that is very well tolerated and provides durable disease control in the vast majority of patients. The patient-scientist synchrony in LAM is unparalleled, and that is a key driving force behind all the accomplishments. We need continued patient engagement, really, for the current slate of studies and for any future study that we might be planning in order for that to be successful. And the future of LAM is very bright, and everyone listening should be optimistic about where the future is headed. So a bit of overview. So LAM is caused by mutations in the tuberous sclerosis complex genes. As most attendees already know, this is a disease that almost exclusively affects women, especially women in their reproductive years. It can be seen in two forms. One is in patients who have known tuberous sclerosis complex, where we call it tuberous sclerosis TSC LAM, or in sporadic cases in patients who don't have tuberous sclerosis complex. The reason I refer to it as simple is that if you compare it to other cancers, they have multiple mutations that are driving the disease. But LAM has just one mutation, a mutation in the TSC genes that drives the entire disease pathogenesis, which means that it is uniquely amenable to targeted treatment. Now, what does LAM look like? If you were to do look at the CT scans of LAM patients, it's the hallmark characteristic of LAM is these round air-filled cysts. And the cysts in LAM are quite unique to where you can often get a good idea for what someone has by looking at their CT scan. And the cysts in LAM tend to be very uniform, round, thin-walled, and they're present all over the lungs. On the left here, where my pointer is, this is an early case, someone with mild LAM, and you can see that there are these few round cysts. And on the right-hand side is someone who has advanced LAM, and here you can see that the entire lung tissue is covered with cysts. Other features of LAM a minority of patients with LAM, probably about 15 to 20% of patients with LAM, can have chylous or lymphatic complications, in which case the chylous fluid or lymph can drain in places where it's not supposed to be. This is a CT scan from a patient in which the chyle has leaked in the pleural cavity, causing an effusion. Analyzing this fluid and determining that it is chyle can also help us diagnose someone with LAM without needing a lung biopsy. And another feature of LAM is the presence of benign kidney tumors called angiomyolipomas. And this is a CT scan from a patient with tuberous sclerosis LAM, where you can see this is the kidney that is entirely replaced by this fatty tumor, and this patient also has these fatty tumors in her liver. And these kidney angiomyolipomas can be seen in about 1/3 of patients with sporadic LAM and 80 to 90% of patients with tuberous sclerosis LAM. Want to point out to all the patients listening that there are international guidelines that exist to help in the appropriate diagnosis and management. These are guidelines that were sponsored by the American Thoracic Society. This is a two-part guideline, came out in 2016 and 17, which cover the major management questions, the major diagnosis questions, and provide an algorithm on a stepwise way how to diagnose someone with LAM. So if you are seeing a physician who may not be as well versed with LAM, these are the articles that you probably want to start them off with to get a high-level overview of the disease and guide them in your right management. One of the other major advancements in LAM has been the development of a blood-based biomarker called VEGF-D. And if you have a serum VEGF-D level that is greater than 800, that is diagnostic for LAM in women who have a compatible CT scan, and that can avoid lung biopsy. So here you are looking at a graph of patients with LAM and all the other diseases that we commonly confuse LAM with. And if you look at patients who have a VEGF-D greater than 800, this is all LAM patients and no one else. But keep in mind, there are LAM patients who do have a VEGF-D level less than 800. So the idea here is that if you have a VEGF-D which is greater than 800 and you have lung cysts, then we know you have LAM without needing to do any other invasive procedures. But if your VEGF-D level is less than 800, that does not rule out the presence of LAM. One last thing about VEGF-D is that we commonly see that patients have gotten a VEGF tested or a VEGF-A tested. VEGF or VEGF-A is routinely commercially available at labs, but that is not the right test to diagnose LAM. The right test is VEGF-D. And at least in the United States, VEGF-D is only available at one lab, which is the TTDSL based at Cincinnati Children's Hospital. And this link will take you to the correct way to process the specimen, ship the specimen, and order the test. So please keep in mind that you need a VEGF-D, not a VEGF or a VEGF-A. And if you have other questions about it, please feel free to reach out to the foundation or this link or really any one of us. And to summarize, if you, as far as diagnosis is concerned, in addition to your CT scan showing characteristic cysts, if you have any one of the following, that is a high serum VEGF-D, if you have tuberous sclerosis complex, if you have kidney angiomyolipomas, chylous effusions, or lymphangioliomyomas, that is confirmatory for the diagnosis of LAM, and you do not need a biopsy if you have any one of these features. And taken together, greater than 2/3 of the patients with LAM can be diagnosed by one of these features and avoid a biopsy. Coming to treatment, this is a landmark achievement and a paper in the field of LAM, which proves that sirolimus is a targeted, effective treatment for LAM. And so this is the data from the MILES trial, in which patients with LAM who had an FEV1 or lung function less than 70% predicted were randomized to receive sirolimus or placebo. The trial length was for 2 years, In the first year, the groups were divided to receive sirolimus or placebo, and in the second year, both groups received placebo. So if you look at the placebo arm in the first year, you can see clearly that the patient's lung function continued to decline, whereas the group that got sirolimus had a stabilization in their lung function. And in the year when the treatment was held, both groups started to decline at the same rate. So this tells us a few things. That one, sirolimus is an effective treatment to stabilize lung function in women with LAM, but also that the effect of sirolimus only lasts for as long as you take it. And for you to have durable effect, we need to keep giving sirolimus over a long time frame. The other thing to note here is that after the women stopped sirolimus, the rate of lung function decline is similar between the two groups. We often hear this assertion that if you once take sirolimus and you come off of it, your lung function may decline faster. Based on this MILES trial, it is very clear that that is not a true statement. Other situations in which sirolimus may work well is the Chylous complications or lymphatic complications that we briefly mentioned before. So this is a CT scan from a patient with LAM who has effusions on both sides of the lung. And this is a few months after sirolimus, and you can see that these effusions have completely cleared away. So to summarize, who should take sirolimus? Based on the MILES trial, patients who have abnormal lung function, that is FEV1 less than 70%, should take sirolimus. Patients who have a rapid decline in lung function, even if they have not reached abnormal limits yet. And how do we define rapid decline? Roughly 100 mLs per year. And in order to make these decisions, it is important not only for your physician, but I think for you as well, to know what your lung function is and what the rate of decline of your lung function is. Other things that we take into account while making these decisions is, do you have a significant disease burden? And we can measure that by, say, if you have air trapping or high residual volume, this is commonly done on lung function testing, or if you're needing supplemental oxygen. As one of the next steps, what we need to do is we need to become better at identifying LAM patients who are more likely to progress. Because if we can identify them sooner, then we can start treatment earlier and prevent a loss of lung function. Some examples could be that, maybe premenopausal patients, maybe patients who have a high VEGF-D level. And we have some work in this regard that I'll share with you later on, which suggests that we are moving in this right direction. A bit about spontaneous pneumothorax. LAM patients are at a high risk for pneumothorax. So this is a CT scan from a normal patient, and this is what a normal lung looks like on a CAT scan. This is a CT scan for a patient with LAM, so you can compare and see that there is just a lot of more cysts in this CT scan. And this is a CT scan from a patient with LAM who has pneumothorax, and you can see the classic cysts of LAM here. And all of this black area is air that has leaked out because a cyst has ruptured and that has collapsed the lung. So that's what a pneumothorax is. When a cyst ruptures in LAM, it causes the air to leak out in the lung linings and makes the lung collapse. So I think every LAM patient should know what a pneumothorax feels like. So the classic symptoms are sudden onset chest pain and shortness of breath. Typically, the symptoms are on one side, and the symptoms are worse when you try to take a deep breath. And I think you should all know these symptoms, and if you are experiencing these symptoms, that may be a clue for you to get a chest X-ray. Majority of the pneumothoraces can be diagnosed on a simple chest X-ray. Also know that most of these episodes happen at rest. Patients often ask if they should avoid certain activities because they might be at a higher risk for pneumothorax. There is no evidence that doing any of the routine activities puts you at a higher risk for pneumothorax. The only activity we ask patients to avoid is scuba diving. The other nuance in pneumothorax in LAM is that there is a very high rate of recurrence. So if you have had one pneumothorax in LAM, there is a greater than 70% chance that you will have another pneumothorax. And pleurodesis is a procedure where you can glue the linings of the lung together to reduce your chances of a second pneumothorax. Now, pleurodesis is not perfect, but it cuts the rate in recurrence by half. So we recommend that LAM patients who have had one pneumothorax undergo pleurodesis because their chance of having another one is very high, and we know we can reduce the risk this way. Typically, the first step is VATS guided mechanical abrasion. This is a procedure where a thoracic surgeon takes a sandpaper and roughs up the lining around the lung to make them inflamed and stick to each other. If this procedure does not work, then typically our next step is to use what's known as to do a chemical pleurodesis. Typically we use talc, which is doing the same thing, which is to create inflammation of the lung linings and allow them to stick to each other. Other things are there is often a tendency to remove cysts or do biopsies during pleurodesis. We typically caution our patients and thoracic surgeons to not do any of these aggressive things because that can often lead to prolonged leaks. And lastly, like in any decision with medicine, shared decision making is essential because we have noticed that often there is a difference in when we as physicians feel that you should undergo pleurodesis versus when the patients feel they're ready to pursue pleurodesis. And this is important. This is a myth that we keep hearing over and over again, where patients are not offered pleurodesis or they don't undergo pleurodesis because of concerns that it might affect their future lung transplant candidacy. This has been looked at in more than one studies where patients who have had prior pleurodesis, they are more likely to have the surgery be technically difficult. They may have more bleeding complications during the surgery, but there is absolutely no difference in the mortality or the length of hospital stay or lung function. And as such, both the Transplant Society and the ATS guidelines, we recommend that prior pleurodesis is not a contraindication to future lung transplant. So my last bit on the overview of LAM is really a list of things that we should stop doing. We should stop doing unnecessary lung biopsies. That is, we really should go through a stepwise algorithm to make sure that we have a need to pursue lung biopsy, because greater than 2/3 of the patients can get the diagnosis without a biopsy. We should stop doing unnecessary kidney resections. Most of the angiomyolipomas can be managed by conservative measures, by embolizations, by sirolimus, and they rarely, if ever, need to be resected. We should stop postponing pleurodesis, waiting for the next event. We should not use off-label drugs, and there are many statins, hydroxychloroquine, doxycycline, letrozole, progesterone, except in individual cases. We should stop discouraging air travel. Air travel is safe in majority of the patients with LAM. Holding sirolimus when antibiotics are needed. This is something else we have seen. If you have a mild infection, you could take your antibiotic in conjunction with sirolimus without stopping treatment. If you have a severe infection, then we may need to hold sirolimus. Waiting until lung damage is advanced before starting treatment. We know that sirolimus is an effective treatment. And if we can start early, we may be able to prevent future damage. Waiting until the newly diagnosed are depressed before offering help. This is an area where I think both clinicians and patients need to become more proactive. Clinicians in terms of asking and seeking answers to the mental health, and patients in terms of not trying to fight this or think that they are weak in some way by if they confess to this. This is an important topic. This has implications for quality of life, and we need to be better about addressing this. sending VEGF-A instead of VEGF-D. We have talked about this. And lastly, we should stop perpetuating rumors. Rumors such as LAM progresses faster when sirolimus is held, or that early treatment with sirolimus may induce resistance down the road, or that sirolimus side effects are intolerable. All of these are myths that are not backed by science. Right. So let's move to the next half of the talk, where I'm going to show you just a few select things that I think are the most exciting things to come out and looking towards the future in LAM. So first is data from single cell RNA sequencing, and this paper actually just came out in print this week. This is a lot of work done by over 24 collaborators at Cincinnati Children's and University of Cincinnati, where what they did was they took lungs from LAM patients who were undergoing transplant, and they dissolved the lung tissue and isolated each cell. And then you study the genes that each cell is that are active in each cell, and you separate each cell according to the genes that are active. So it completely reimagines the lung and groups clusters of cells that are similar together. And if you notice here, there are a number of different cell types in the lung, but this little pink cluster, these are the LAM cells. So it's just fascinating to know that this small cluster of cells in the otherwise large compartment of lungs is creating so much havoc. But the reason this is important is that this is giving us direct knowledge about what is happening in a LAM lung from LAM patients, as opposed to animal models that do not reflect the LAM pathology to the full extent. And I should mention that all of these experiments are made possible by generous tissue donation from the LAM patients and funding from the LAM Foundation. And one of the key findings to come out of the single cell RNA sequencing is that when you compare the genes that are active in LAM cells, the LAM cells appear to have a lot of similarity to the uterus. One of the key questions that remains to be answered in LAM is, where do the LAM cells arise from? And this technique is getting us closer to that answer and has suggested that uterus might be the source of LAM cells. And we won't go through this complicated map, but this is just to show that this is giving us a very granular look at all the pathways that are active in patients with LAM, and we are getting a very good idea of what the LAM cells are doing, what sort of interactions they are having, and how we can better target these interactions to find new therapies. So in summary, because of this technique, we will understand LAM at a level that was never possible even a few years ago. And the insights from this analysis will help us develop a number of new biomarkers and new treatments for LAM. And really a big thanks to all the patients who contributed tissue and funding from the foundation. And switching gears, so the other recent finding thing in the past year is this analysis from the NHLBI LAM registry, where we looked at the natural history of LAM in this carefully collected database in the late 90s and early 2000s. And so the one thing which is clear is that the rate of lung function decline in LAM is about 90 mLs per year. Now, in putting this in context, an average normal person without any lung disease declines at a rate of 20 to 30 mLs per year. So on an average, women with LAM decline at about a 3 times faster rate than a normal person. This is something that we were very happy to find, that the average survival in women with LAM is more than 20 years. And this is something that it gives me pleasure to say this to women when they have read on the internet or heard from somewhere else that the average survival in LAM is 8 to 10 years. That is just not true. And also keep in mind, this is data before sirolimus came on board. So it is very much likely that this median survival is going to be much higher in the Sirolimus era. The other point of note in this analysis to us was that your baseline lung function and baseline menopausal status, they both seem to affect future progression to death or transplant. So if you had a starting lung function greater than 70%, you had a much lower chance of progressing to death or transplant as opposed to a lung function less than 50%. Similarly, postmenopausal women tended to have a much lower chance of progression to death or transplant as compared to premenopausal women. And all of these factors are, and this database is going to help us really realize the personal LAM risk calculator aspect, where we can start individualizing patients' prognosis and helping make treatment decisions. This is data from the Miles cohort, which and this is, I'm showing two graphs here. One is looking at VEGF-D, other at menopausal status. So we'll go one by one. So on the VEGF-D graph, key findings that came out were, if you were on placebo, meaning you are not getting treatment and your VEGF-D is low, there was not a whole lot of lung function decline even on the placebo arm. But if you were on a placebo and your VEGF-D was high, you tended to decline the fastest. Now, if you were on the Sirolimus arm and your VEGF-D was low, again, your lung function was stable. But if your VEGF-D was high and you got Sirolimus, you tended to have a better response. So what that suggests to us is that if you have a high serum VEGF-D, that might predict that you will decline faster. Conversely, that might also predict that you will respond to treatment better. And on this graph, let's look at menopausal status. So if you're in the placebo arm and you're premenopausal, these are the open circles, you decline the fastest as compared to the placebo arm on the postmenopausal group. But both treatment groups derived a benefit from Sirolimus. And this is an analysis looking at the survival following lung transplantation in LAM. This was done by Umair Khawar and Dina Yazdani, both a pulmonary fellow and a resident at University of Cincinnati. So what we have found is that over the past 10 to 15 years, the number of transplants in LAM has stayed rather constant, somewhere around the 9 to 10 mark. This data is only looking till the end of 2016. Lately, it does appear that there is a trend towards reductions in annual transplant, and that might be an effect of Sirolimus. That needs to be looked at again in the next few years to really be conclusive about it. But the major finding from this analysis that I'd like to share is that the average survival following lung transplantation in LAM is 12 years. And to put this in context, the average survival following lung transplant in all other lung diseases is about 6 years. So on average, women with LAM, even if they undergo transplant, are living twice as long as any other lung disease. And all of these graphs are essentially us slicing and dicing this data 100 different ways. But this message did not change, that women with LAM fare better after transplant than any other lung disease. So the key messages here is that LAM is not the death sentence it was previously made out to be. There is every reason to believe that Sirolimus will prolong the survival even beyond the greater than 20-year mark. Lung transplant outcomes in patients with LAM are better than any other lung disease. I think you should know your FEV1 and the rate of disease progression, and that we are working on creating LAM risk calculators and hope to have them available soon. On that front, this is a never before seen sneak peek at what a LAM prediction model that we are working on will look like. And this is really all thanks to Anushka and Rhonda, who are two super smart biostatisticians working at Cincinnati Children's, who mostly speak in a language that goes above my head. But this is what the model will look like, where we have some very simple, easily available variables like your age, your lung function, your menopausal status, your current FEV1, and it will tell us at the end of the next year what we think your next FEV1 will be, what we think your rate of decline will be, and what is the probability you will be declining faster. And we think this will be a nice decision aid in the clinic for clinicians as well as for patients to make decisions about when they should start treatment. The other few other things to focus on is that the immediate next steps in LAM are clear. There is a lot that needs to be done, but these are a few things that we think should be high priority. We need to refine the use of sirolimus. And the two key studies there are MIDAS, which is a registry to establish long-term safety and efficacy of sirolimus, and MILD, which is a study to see if early administration of low-dose sirolimus can prevent future lung function decline. We need to develop biomarkers to personalize sirolimus dosing so that we stop talking in terms of you need to be on 1 milligram or 2 milligram. We should know what every individual patient's need is. And lastly, I think we need to develop a method which can let us image the total LAM cell burden, similar to the PET scans that we are familiar with in cancer. One slide on MILD. If you're not familiar, MILD is a study aimed to answer the question that if you start taking low-dose sirolimus early when you have normal lung function, can it help preserve future lung function decline? This makes intuitive sense, but this needs to be studied properly to answer this. This is a very important study in the field for LAM. If you recall, in MILDS, the patients had to have an FEV1 less than 70%. This is the next phase then the next big question we need to answer with regards to sirolimus. All details regarding the study are here. The lead coordinator is Sue McMahon. I would sincerely urge you, if you have a normal lung function, that is FEV1 more than 70%, and you're not on sirolimus, please consider enrolling in MILD. And please feel free to reach out to Sue McMahon or myself or Frank McCormack if you have any questions about MILD. This is a very important study. This is a slide looking at home spirometry. I think I alluded to this. One of the things that I think will come out of as a legacy of COVID will be an increased emphasis on telehealth. And home spirometry in LAM is something we have been studying in the context of RESULT and MILD. So this is an example of a home spirometry data from a patient with LAM. And if you notice at this, look at this graph, it is very clear that this person is declining. And based on the office PFTs, it took us about 6 months to really determine that this patient is declining. And that is frankly on the earlier side of things. Normally it could take us 9, 12, or 18 months to figure out what someone's real trajectory on a lung function is. But if you look at the home spirometry graph, just by virtue of having all of these data points, it was very clear, even in 3 months, what this patient's trajectory is. And so I think this is the future of lung function monitoring in LAM, where patients have a spirometer at home. You're giving us a lot more data points, and we are significantly shortening the time in which we can make decisions and understand disease trajectory. This is unpublished work from Brian Shaw, who was a resident at University of Cincinnati and is now starting a fellowship. And this is a survey taken from about 300 patients with LAM generated through the foundation, and where we found that about 1/3 of the patients say that they have cyclical variation in their symptoms, which seems to correspond to their menstrual cycles. And this is something that we have seen in the clinic as well, and also corroborated by this large survey. And we think this might be a useful prognostic marker, in the sense that patients who have this variation may have a difference in their disease trajectory as compared to patients who don't have this variation. And on the same survey, when we asked patients who report cyclical variation, what happens to these symptoms if you're on sirolimus? If you notice here, when patients take sirolimus, majority of them report that their overall symptoms are better. But the menstrual cycle variability symptoms, for a vast majority, is really not impacted by sirolimus. So that's another area that we need to get better at, and we think this might be a unique phenotype to target. And we are actively planning a study to launch to better study this using a home spirometer. but we are affected by COVID-19. So whenever we get a chance, this should launch soon. And lastly, in terms of imagining the future, we are also actively thinking about what a continued LAM registry, or a MIDAS 2.0, if you will, would look like. As you know, MIDAS is a natural history study where we are seeking to establish the natural history of disease progression and understand the long-term safety and efficacy of sirolimus. The current model of MIDAS is that it is driven by a number of sites and investigators and research coordinators, but this model is likely not sustainable. I would like to imagine a world where every LAM patient in the country is connected to a central database where you have access to the database, you enter your own data, and this gives us a global connected community where the next time we need to plan a study, we know exactly where the patients are, we know exactly who to target, and we can drastically reduce the costs and the planning and make just the entire research endeavors in LAM a lot more efficient. This is a lofty goal, but this is what I think we would like to reach in the next few years. Just to finish off, I think my last two slides, if you want to remember just a few things, is just know that the future of LAM is bright. We have an effective therapy that is safe and well tolerated. The majority of the rare diseases cannot claim to say this, so we should really feel good about this. We have a disease-specific biomarker that can help us diagnose LAM without a biopsy in over half of the patients. The pace of discovery in LAM is faster than any other disease in medicine. All of the things that we have talked about, we have a treatment, we have a biomarker, and all of this in less than 2 decades. This is pace which is unparalleled. And the LAM community, both scientific, clinical, and patient, this is a very knowledgeable community. This is an organized community. This is a motivated community, an engaged community, and this community works very well together. And that has been the engine behind this success. So let's keep it up. And in terms of looking towards the future in LAM, what do I think the future in LAM looks like? I think in the future, LAM looks like somewhat like this, where we have a clear understanding of where the LAM cells arise from. And that understanding leads us to develop new biomarkers and new treatment options. And we have personalized prognostic estimates, i.e. the LAM risk calculators, which helps each individual patient make a better informed decision about their management. And we have novel imaging. We didn't really talk about it, but there are some promising signals that are already emerging in our ability to be able to identify LAM cell burden in the body. And we have a future where we know what is the best time to intervene and avoid future lung damage. And again, we could use your help in this by enrolling in MILD. Imagine a future in which a lot of the disease monitoring is done at home in the control of patients using telehealth and avoiding a lot of the hassles of travel that are in the current healthcare system. And lastly, a whole immersion integration with patients and research endeavors. This is already a community which is very well connected, very engaged, very motivated, and an active part of endeavors. But if you could imagine, I think we need to take it to the next step, like the MIDAS 2.0, where you are in control of these endeavors and you're driving this and making it a lot more efficient than it is currently. I'll stop here, and if you guys don't know, the LAM Foundation should be your one-stop shop for all things LAM. It's the phone number, the website, the map here is the clinic network, and stay tuned for a lot more information about the Lamposium in your living room sessions, where some sessions have already happened. A lot more are planned. Sue Sherman and the staff at the foundation is working tirelessly to make sure that you continue to stay updated. And I'll stop here and I'll be happy to take any questions. Thank you for your attention.
Thank you, Dr. Gupta. If you have any questions, please type them into the question sign icon into the chat box that pops up. Your questions will come to me and will relay them to Dr. Gupta. We already have a few questions. So the first question is from Elizabeth, and she asks, have there been any LAM patients with severe disease, FEV1 under 50, that have recovered from COVID-19? And do you believe LAM patients with severe LAM disease can recover from COVID-19?
Elizabeth, I'm not sure that we have granular data in terms of what individual patients who FEV1 was who were affected by COVID-19. My sense is that of the 5 or 6 that we know, that 1 or 2 did have severe disease, and everyone seems to have recovered well. To your point of can patients with severe disease recover? The answer is yes, they can. I'm not sure that we really know the answer to that. I think logically we would think that they are at the highest risk of complications, but I don't think that that means that if they were to get it, that they can't recover. Keep in mind that in 80% of the patients who get COVID-19, it is a mild illness that does not require hospitalization.
Thank you, Dr. Gupta. Our next question is, do you think that the masks LAM patients wear need to be N95 or KN95 masks, or will cloth masks with a filter do?
Yeah, good question. N95 or KN95 masks are really meant to be used by healthcare providers while doing procedures which are considered aerosol generating. For a normal day-to-day person, typical cloth mask is sufficient.
Thank you. My pronunciation may be off on this, but can chyle leak through the uterus? It's spelled C-H-Y-L-E.
Yes, it could happen. It is very rare, but it could happen.
Okay, thank you. Our next question is, what is the relationship between LAM and menopause and a woman's reproductive organs? Someone had bleedings recently and they wonder if their estrogen levels or something else could have something to do with it. And are there any specific tests to check up on that?
Bridget, I'm not sure that I fully understand this question. This might be a question where you may want to just connect the individual patient with me, and so I can understand the specific question better. In general, though, I mean, we know that postmenopausal women have a slower rate of progression of disease as compared to premenopausal women. In regards to whether you can measure estrogen levels to check for menopause, yes, you could measure estrogen levels to check for menopause, but I'm not sure if that was the intent of the question.
Somebody's asking if you can talk about the result trial and how that is going.
The result trial is a trial, and it's a phase 2 study in which we are looking at the addition of resveratrol to patients who are already on sirolimus. There was a trial conducted at the University of Cincinnati, and the result trial just finished all of the study visits 24 hours ago. So we should have top line results, I would think, by fall this year.
Thank you. Our next question is, what is the best contraception options for patients with LAM?
Yeah, so the contraception options for patients with LAM, if at all possible, avoid all hormonal supplements. So you could use barrier methods or copper IUDs. If those are not practical, then the next step is to use low-dose progesterone, whether it's a low-dose progesterone pill or IUD, followed by other progesterone-only alternatives. The key point to remember is to avoid estrogen at all costs.
Thank you. Our next question is, if there's no sign of pneumothorax or any other issues, what could be the reason for severe chest pain?
We hear that a lot from LAM patients, that they have periodic episodic chest pains, and I'm not sure that we really understand that. We often ascribe to this theory that perhaps that represents some subclinical cyst rupture that wasn't big enough to cause a pneumothorax, but that's just a theory. We really don't know the answer to that.
Okay, thank you. Our next question is, how do allergies affect the lungs in patients with LAM?
Allergies could affect your symptoms. For example, if allergies could make breathing difficult, could cause wheezing, could cause chronic cough. Per se, there is no known direct correlation between allergies and at least your disease severity or disease progression in LAM. A key point to remember, though, is that about 20 to 25% of patients with LAM do have reactive airways, similar to how patients with asthma do, whether that represents concomitant asthma or that is just because of LAM. So you may have more of a asthma type symptomatology in conjunction with your allergies, but I don't think that necessarily represents worsening of the LAM.
Thank you, and we have time for one more question, and this question is, how does one start the home-based LAM monitoring, and what tests need to be done from home, and how often?
I think this question is mainly referring to home spirometry. I think you should talk to your physician about if you're going to use this clinically. There are a number of spirometers that are available to purchase from the web. We are currently studying home spirometry in the context of 2 clinical trials. So folks enrolled in those trials, we had given them the machines. So I think we will have more clear answers on the utility of home spirometry once we are done analyzing all of the data. But at least from a handful of patients, it appears that it would be beneficial. With regards to individual devices and monitoring strategies, I think that's something that you should discuss with your LAM provider. I think once a week measurements or at most twice a week measurements should be sufficient, though.
Thank you so much. And I know we have some questions we did not get to. If we did not answer your question, I will be passing those along to Dr. Gupta, so we will get those answered for you. Mary, do you have any closing thoughts for us today?
I just wanted to thank Dr. Gupta for giving us this past hour and the information. I think there's a lot of interesting things going on, and I'm really looking forward to see what's coming next. And I also thank the American Thoracic Society and the Public Advisory Roundtable for giving us this opportunity. Thank you.
Thank you, Mary. And Dr. Gupta, do you have any closing remarks for us?
Thanks, Bridget. No, I just want to echo what Mary said. Really thank you for all the attendees, and please send us the questions. Be happy to answer or talk with you individually, whatever helps. And again, thanks to ATS for giving us the platform, and thanks to all the patients for the generosity, for your contributions, and for really inspiring us to keep moving.
All right, thank you everyone for joining us today. This webinar has been recorded and will be posted on our website in about a week's time. So thank you very much and have a wonderful day.